This session is the era of 988. I am excited to be your moderator for this session. And without further ado, I'm going to go ahead and turn it over to our presenter today, Jamie.
Hi. So I'll go ahead and introduce myself. My name is Jamie Seller. I'm the Chief Strategy Officer for RI International, which is a lovely title I gave myself probably about 5 or 6 years ago. Really what it means is my day-to-day is consulting nationally, internationally, really around crisis system optimization. Also in charge of our training programs, a little bit of business development, but really my background is as a licensed professional counselor in the state of Arizona, is really historically always to work in crisis centers, whether that's mobile crisis outreach teams, inpatient psych hospitals, respite level of care, detox centers, locked inpatient psychiatric hospitals, level 1 psychiatric acute hospitals, or outpatient programming. Crisis has always been kind of my first love, and what I've been able to do then at RI International is start to translate that a little bit and really start to have a good understanding of what's going on in the States, what's going on at the national level. My goal today is to really do a presentation on an overview of 988, you know, where we've come, what it is, where we're going, a little bit about what it's doing now. And I do make up that many in our audience are going to be absolute experts in 988, maybe working call centers, maybe formerly working at the Lifeline, really have a great understanding of this. But I do think that there's certainly people in the audience that maybe do need a little bit deeper understanding of what it is, where we're going, and what we're going through. So my goal today is to give a high-level overview with a few deeper dives. We can certainly answer some questions, at the end of the conversation today. So I want to go ahead and discuss a little bit about the need for a 988 system. So you can see the slide now that's talking about a country in crisis. We probably all understand that there is a need for 988, but the history moves us from understanding that behavioral health crisis is a life-threatening issue that deserves the same attention as other life-threatening issues, such as medical emergency, car crashes, fires, even criminal acts. I think for too long, we've kind of been sitting on the sidelines looking at behavioral health as kind of a second place to physical health. And as such, our systems are over-reliant on the physical health system, go ahead and take care of high acuity. And we kind of work at the fringes of behavioral health, mental health, substance use disorders kind of coming through. So I like to talk a little bit about the concept of, deaths of despair, because for years, we only looked at the crisis in behavioral health as being related to suicide. And the reality for those of us that work in there, we know that's a small percentage of the life-threatening issues that do occur to people who are in a behavioral health crisis. So I like to kind of coin that term, deaths of despair. And the term deaths of despair comes from Princeton economists Ann Case and Angus Deaton. And really what they wanted to do was understand why we were seeing falling life expectancy in the US. What they learned is the fastest rising death rates in the US over the last 20 years are suicide, overdose, and alcohol-related liver disease. So really what we started to see then is if we start to lump these together, and you can see the numbers on your screen, I won't go through it, these things have increased between 56 and 387%, depending on the age cohort, in the last 2 decades. And they highlighted this in the book, Deaths of Despair and the Future of Capitalism. So they were definitely looking at it from more of an economic viewpoint. But the reality is, we all know that we've been seeing increase in suicide rates and issues, these deaths of despair, those that are certainly working in the field, highlight that against what we're doing against the other leading causes of death. We're starting to bend the curve back, heart disease, doing a little bit better job than we were, 10 years ago. Cancer, a little bit better job than we were doing 10 years ago. But we start taking a look at these reasons and we start thinking that something does need to happen. So let's go ahead and we'll jump forward. Like I said, I'm not telling anybody probably in the audience anything new, but I think what we tend to focus on is some of the changes that we've seen in the last decade. And I've been a licensed counselor since 92, maybe 93. I think 93 was the first year I got licensed. And I've seen changes in the last 3 or 4 years that I actually never thought I would see in my career. But things for us in the crisis field actually started in about 2012. So that first paper that you see there is the basically the national guidelines, the strategic plan for suicide prevention, kind of the strategy came out of the Surgeon General's report, Surgeon General's office. And really what they were focused on is why Why are we seeing these increases? And they were focused on suicide, but once again, we've seen that in all of these deaths and despair. So this was a kind of a nice white paper, and they had 4 strategic directions. They had 13 overall goals, but where providers, agencies started to lean in with strategic direction number 3, which was around treatment and supportive services. And really what they had is kind of 9 guidelines, 9 thoughts around treatment and support services. And really we kind of started to lean into 2 of them pretty heavily from the provider side, because there were things that we could do and things that we inherently knew needed to happen within the community. One was the provision of evidence-based treatment as soon as possible after suicide risk is identified. And if we think about that, makes sense. Somebody's identified as having a potential life-threatening issue related to their behavioral health, suicide, or potentially substance use disorder, alcoholism, any other number of issues that are out there. You should get care that's evidence-based, practice-informed, best case scenario, as soon as possible after that. But what we see repeatedly across the country is behavioral health crisis care comes in the back of a police car. The first line of defense in the streets where people live, work, and play is going to be a uniformed officer, not a mental health not a mental health professional or paraprofessional. And usually the facility of first resort for people in a behavioral health crisis is going to be an emergency department, or often case, it's going to be somebody that's going to jail to go ahead and provide that security and safety while they're starting to think something, while they're starting to sort things out. With the focus being, it's a safe environment. There probably was a misdemeanor crime that they could go ahead and go with. So that was the first thing, is we think that there should be a provision of evidence-based care as soon as possible once it's identified as being needed. The second is there should be multiple points of access to appropriate treatment and a focus on providing support in the least restrictive environment. And once again, emergency departments and jail are not a least restrictive environment. Police officers out in the street are not the least restrictive environment. But what we do see across the country, and you probably are seeing in many of your counties in California, is there's not ease of access and low barrier to get into appropriate crisis care. So you end up in the ED, you end up waiting there for an extensive period of time before you get transferred to an inpatient level of care that could be 18 to 36 hours after your initial crisis started. So from that paper that came out in 2012 from the Surgeon General, the National Action Alliance for Suicide Prevention created the Crisis Now white paper. What they did is they brought in about 40 consensus best practice experts from around the country, from government, from law enforcement, from academics, from provider networks, from peer-run organizations. And they said, look, if you were going to go ahead and create a system that provided low barrier access that aligns very well with the Surgeon General's guidelines, what would it look like? And what they kind of immediately recognized is that every state's doing it different. Every county is doing it different within those states. But what they wanted to do then is say, there's got to be a state somewhere or a county somewhere that's doing this very, very well. And what they kind of realized, there's nobody doing it perfect, but there's a couple of states that were doing it pretty well. One of those states is Arizona, where I happen to live. In Maricopa County, 4th most populous county in the country, currently about 4.43 million people reside, does crisis care pretty well when it comes to mobile teams and when it comes to facility-based services. And we've got an excellent state-run crisis call center. When they looked at Georgia, they said Georgia does a great job with all the technology that they need for the Georgia Crisis and Access Line, which is their 988, their crisis contact center. And by an offshoot, does a very good job with their mobile crisis teams so that everyone in the state has access to that. They just have some challenges on the facility-based side. So when you start to match up what's going on in Arizona, what was going on in Georgia, start aligning their best practices and throw some sprinkling in from Colorado, a little sprinkling in from New York, really what you've got then is guidelines on how behavioral health crisis care should be delivered. Then in February of 2020, the federal government published its national guidelines for behavioral health crisis care, which really took that Crisis Now model and energized it, made it a little bit more focused, started to define better what crisis services are and what the funding mechanisms underneath them need to be. Now, the benefit of all of this work rolling into the SAMHSA national guidelines is it now starts to have funding opportunities behind it. It now starts to support those states in a vision and a pathway to go ahead and create their crisis systems moving forward. So really what we're kind of focused on is we're looking through here. And as the Crisis Now white paper came through, I'll be honest, there wasn't quite the realization of what we were looking at as it started to come through. But what we focus on in both the national guidelines and the Crisis Now white papers, having three core services. One is a crisis call center hub that operates as an air traffic control model that can be accessed anywhere in the community 24/7 to provide an immediate low barrier response for anybody in crisis. Now, what we tend to see in systems that have had good, strong quality crisis call centers is they resolve between 88, 92% of the calls that tend to come in over the phone, which means there's not a requirement for someone to go to a higher level of care, have a crisis mobile team come on out, involve the police. But for those other 8 to 12% of cases that can't be resolved over the phone, probably the best first bet for that person is going to be a crisis mobile team. And under the federal guidelines in Crisis Now is a two-person team with a licensed clinician and some form of paraprofessional to increase safety and increase the chance for engagement. Having that two-person team come out to where people live, work, and play with the goal of helping them stabilize in community. And what we tend to see here in Maricopa County, we're running 23 mobile teams a day, 10 hours a piece, is we're stabilizing about 78 to 80% of the folks that we see and allowing them to remain in community during that 75-minute to 90-minute intervention, which means that there is still a percentage of folks that are going to need to go to a higher level of care because they can't be stabilized at home or in community for safety issues, for detox issues, for a host of other issues. The primary level of care beyond mobile teams should be that crisis receiving center, which should be low barrier, with the ability to go ahead and accept everybody that comes in for service and going ahead and keeping them in a safe, once again, behavioral health focused, evidence-based practice program immediately after it's been identified that that's the level of care that they need, as opposed to going to an emergency department and languishing. So if we go ahead and we take a look at how things arrange, go ahead and you're going to hit maybe a couple of buttons here. As they were thinking about this, they weren't thinking of the analogies. I'm thinking, Angela, you might want to press a button. Go ahead and hit the other two as well. And really what we're focused on at that point is the Crisis Now white paper came out, they weren't really thinking of the analogies to emergency medical systems. But there already is a crisis call center for fire, ambulance, and law enforcement. It's 911. And really what we think of these crisis call center hubs should be able to take a note from 911. They're going to always pick up the phone. They've got the technology. They can start to coordinate and organize those types of crises in the community. And instead of police coming out and being that first line of defense, and remember, police will go see anybody, anytime, anywhere. It should be a crisis mobile team that's really doing the same and only bringing police in when there is an actual issue of public safety, which we see probably less than 3% of the calls that are coming into a crisis line. And instead of the primary facility providing care for someone in a behavioral health crisis, being emergency departments and jails, it should be a crisis receiving center that can bypass the emergency departments with direct admissions. This is the system that really has been kind of in place for in Arizona strong since at least 2014, and in some form since about 1996. So I just kind of want to focus a little bit on that 988 center, which is going to be a little bit like 911. But I'm going to then have a little bit of a discussion about some of the differences, because 988 is not a perfect analogy for 911. There are actually some dramatic and striking differences, but for a level of care of being willing to help anybody, anytime, anywhere, 24/7, those analogies should go ahead and stick. So really what we're starting to focus is in 2020, Congress designated the new 988 dialing code to operate through the existing National Suicide Prevention Lifeline. So SAMHSA is the lead federal agency on this. They work in partnership with the Federal Communication Commission. They work with the Department of Veteran Affairs. They really work together to make the promise of 988 a reality for America. So moving to this 3-digit dialing code, it really is a once-in-a-lifetime opportunity. Like I said, we started thinking and talking about this, several years ago, but we never thought it would be actually moving this fast through the state. And really what they did is they were able to piggyback on the existing National Suicide Prevention Lifeline. Sometimes it's only just called the Lifeline. Now, of course, 988 is more than just an easy to remember number. It's that direct connection to compassionate, accessible care 24/7 always is going to pick up the phone. And in the SAMHSA guidelines, we really talk about crisis care as having no wrong door, having no barrier. You're going to work with anybody, anytime, anywhere. And call centers will always pick up the phone. They may not be the best place to support. They may need to bring in additional mobile teams. They maybe have to direct somebody to another level of care. Periodically, they may need to bring in law enforcement or ambulance services in a rescue, but they're always going to go ahead and pick up that phone. So as we kind of start thinking a little bit about this, 988 needs to be a direct connection to this compassionate, accessible care for anybody experiencing mental health related distress, without thoughts of suicide or mental health or substance use crisis. SAMHSA sees 988 as the first step towards a transformed crisis system, in much the same way as emergency medical services expanded in the US. In pursuit of this bold yet achievable vision, SAMHSA is first focusing on strengthening the infrastructure behind the actual call center for what we see is going to be capacity needs that are coming through. That phone is going to get rung a lot, and I'll talk to you a little bit about what we're projecting for the next for the next 5 years as far as total number of calls that are coming in. But really what's going to be exciting about it is then moving into how it strengthens the rest of the system. I'm going to talk a little bit more about that as well. So when we think about the lifeline, let's go ahead and jump into the next slide. So I want to hit this before I talk about what the lifeline is. So the biggest sentence in this one is, we know that remembering, I need to move around here so I can actually read a little bit better. We know that remembering a 3-digit number beats a 10-digit number any day, particularly in times of crisis. The reason going from a 10-digit number, so in Maricopa County, it's 602-222-9444 is our local crisis number. What I can tell you is 99% of my community doesn't know that particular number. But they will know 988. It's going to be easy to remember, easy to access. But I think that there's a couple of other reasons that it's really kind of important for us to have. One is, I do think as 988 starts to get marketed, as it starts becoming common knowledge, as it starts becoming kind of the very fabric of what we're doing, just like 911 is, it helps to destigmatize reaching out for help. We've got a current number that is utilized if you are in a behavioral health crisis or think you're in a behavioral health crisis. So 911 had an estimated 240 million calls last year in the US, 240 million calls. I don't know what percentage of that were true emergencies, because we only have 334 million people in the country. I don't think I called 911, last year, but seems like 2 out of every 3 people might be making that phone call. So having that dedicated number starts to demonstrate, I think, a couple of things. One is that behavioral health crisis is a crisis, right? It's not just something you got to deal with. It's an actual crisis. That getting help during your crisis is a normal response, so much so that there is a number specifically designed to help you when you're having maybe one of your more challenging days. And I think on a very basic level, what it's starting to do is move the conversation from behavioral health crisis as just being something you need to get through to access to care as an essential service. We fund behavioral health crisis care different than we do criminal justice crisis care, fire department crisis care. It's a completely separate animal. But once again, when we go back to those deaths by despair, it's a life-threatening situation that should be an essential service in the US. I think the other part of the push for 988 is it starts to begin system integration. So imagine if you had 911, but it didn't have the opportunity to dispatch police or fire. It was just kind of a supportive conversation, but they really couldn't do that for you. Or imagine if the ambulance came to pick you up, but they didn't have an emergency department that they could take you to. So as we're starting to roll 988, we start to see across the country that there are a lot of places where those crisis call centers are a silo, disconnected from the rest of the system. And really what the goal is, and we'll see a slide that talks a little bit more of that, the goal of SAMHSA, the federal guidelines, those of us that are working at the national level, kind of promoting and pushing these things, is that we want a system of care that is considered an essential service so that anybody, anytime, anywhere has access to the right level of care that they're going to need to support them with their life-threatening particular issues. Now, we think it's going to happen quicker than 911 came in. So if we take a look at the first call for 911, it came in 1968. I think it was February of 68. If we take a look at the first call in LA County, it was October of 1984. So it was about 16 and a half years later that LA County started doing 911. As of July 16th of last year, 95% of the entire country had access to go ahead and call 988 and something happening. So as we're looking here, what is the National Suicide Prevention Lifeline? I think it's a couple things. One is it is a network of approximately 200 crisis contact centers that are kind of operated independently of each other. So it is a network. It's not one agency. It's not the National Suicide Prevention Lifeline is running every single one of these. What it is 200 centers that have kind of a common goal and a few guidelines that they need to follow in order to be that center. They are 24/7, 365 free confidential support that can be accessed anywhere in the US. Always will go ahead and pick up that phone. California currently has 12 NSPL centers, which now are 988 centers. Last year, they took 3.6 million calls, texts, and chat. But we do anticipate those numbers are going to start to increase fairly dramatically. We anticipate in year one, which should be, we're currently smack dab in the middle of it, of having 9 million contacts. Then we anticipate year two, 14 million, and then year three, 18 million, year four, 21 million, and year five, 24 million contacts. Now, even at that 24 million contacts, that may not be everybody that's in a behavioral health crisis is still calling. Remember, 240 million people call 911. Conservative estimates, real conservative estimates, have about 10% of those calls probably would be better served through 988. We'll talk a little bit more about some of those other numbers. But even if we're taking just 10% of the calls coming through 911, that would hit us at 24 million. And there's a lot more out there that we would certainly be able to benefit through. Chats are answered through the website on your screen right now. Once again, it was established in 2005. Any language, hearing impaired, anybody, anytime, anywhere in a behavioral health crisis has the opportunity to go ahead and get connected there. So what happens when you call? Well, you get an automated greeting, first thing that happens, and that automated greeting is going to say something like, you've reached the National Suicide Prevention Lifeline, also servicing the Veteran Service Line. If you're in emotional distress or suicidal crisis or are concerned about someone who might be, we're here to help. Please remain on the line while we route your call to the nearest crisis center in our network. Now, this also gives additional opportunities or options for folks that are veterans or speaking Spanish kind of coming through. What happens then is that call gets routed to a local crisis contact center. So those local contact centers know the areas, they certainly know the resources. You can certainly do things from a distance with some of the, you can certainly do things from a distance when you've got the technology, go ahead and support that. But it may be easier for a person in crisis to connect with someone that knows their community. However, if a local center is not immediately available, and some of the smaller, more frontier rural call centers may not have the ability to take 6 or 7 calls at the same time. They may have the ability to take 2 or 3, but what happens when you get a surge or something happens, those calls then get transferred to a backup center, which may be out of state. And part of the funding that we're saying is really designed to get those backup centers up and running to make sure that nobody has to wait on the line or gets a busy signal for too long. What happens then is a person trained in crisis will answer that transfer. And support that's going to be given, which is a little bit different, we'll talk about it between 911 and 988, is the goals are really to support somebody to be safe, to provide whatever it takes to go ahead and be able to resolve those issues on the phone. Now, there is no time limit. I've seen call centers across the country, and what I'm going to tell you is historically 15 to 20 minutes is what they tell me is the average call time. Some may take 30 minutes, some may take 45 minutes, some may be more information referral and take a few minutes. Generally, there's going to be no scripts. It's not going to be as protocolized as some other things. Safety planning can certainly be done, but really the goal is to stabilize the community or stabilize the person that's on the phone, connect them with community. And what we do tend to see is at times a rescue may be needed. And that involves, I need to send police out there, EMS. And that happens maybe 1 to 3% of the time, depending on kind of who you're talking to. Through the 988 number, through the Lifeline, they estimate it to be about 1%, but I have seen some call centers that are running up to 3%. So between 1 and 3% are going to need a rescue. So I'm going to just ask a couple of questions, and I'll go ahead and give the answer to you as well. Are 988 and the Lifeline the same? Yeah, 988 is the easy to remember number that reaches what is commonly known as the Lifeline. But just to kind of keep you informed, you're going to hear me talk about the National Suicide Prevention Lifeline a lot, NSPL a lot. The full name is changed to the 988 Suicide and Crisis Lifeline. I don't hear that a ton. I do hear NSPL, I do hear Lifeline, I do hear National Suicide Prevention Lifeline. And I think what we're going to hear more is just 988 kind of coming through. Is 988 available for substance use crisis? Absolutely. Really, any type of crisis, we're going to go ahead and be able to manage, whether that's psychosis, substance use, suicidal thoughts, something, depression, something in between. When there was first talk about going to a 3-digit number, once again, it was kind of designated through the National Suicide Prevention Lifeline. They thought it was going to be for suicide, right? But what we start to realize is the majority of folks that are calling in crisis may have some suicidal ideation, but there may be other things that are going on as well. It might be substance use, it might be psychosis, it might be some organic issues that are running through, it might be situational stressors or depression that are starting to kick in that may or may not have some suicidal undertones to it. And what we started to realize is when you've got something as powerful as this and you start to limit access and who can call and who can't call, it starts to become a problem. So fairly quickly early on, it did become a full behavioral health crisis call center, not just for people experiencing suicidal ideation. Does 988 track the location of people who call, text, and chat? So the answer to that is no. Go ahead and click. So tracking becomes a little bit difficult to go ahead and do. What they end up doing is that when you reach out to call 988, the Lifeline crisis person, the response to you, they'll know what your number is if you call and text. They'll know what your IP address is if you go ahead and you utilize chat. But beyond that, they're not going to know who you are. They're not going to know really where you're located. And you're not required to give them any information to receive support from the 988 Lifeline. Now, if a 988 crisis counselor makes an effort to gather information during the call or text or chat, it may be that they do want to send rescue and they're kind of trying to find out where you are, or they may be looking to go ahead and connect people to ongoing support, you know, knowing what city you are in or what zip code you might be in or what area code you might be in may help them find something close to you in the community that you can go to. Or it also may be just kind of evaluate 988 Lifeline services where calls coming in and just kind of know that. But historically, what we've seen is I can't trace you. I don't know where you are, especially if you've got calling via a cell phone. I can get a general area at best, but can't absolutely find out where you are. Does the 800-273-8255 number still work? Absolutely. And it's going to continue to work. You know, people have used that number for years, right? They've got it memorized. 1-800-273-TALK. It may be on their refrigerator. Some folks may feel more comfortable calling that 1-800 number versus 988 just because they feel that their issues don't amount to needing a 3-digit number, but they may still reach out for help thinking it's something a little bit different. So what I can say is sunsetting a crisis line number, generally you don't do it. Someone may have called that number 10 years ago. It's still ingrained in their brain. It may be on their fridge. It may be the first number in their phone book. It may still be in their cell phone that they've had for the last 10 years. And you want them to be able to reach out in any way that makes sense to them that they understand to go ahead and get the help that they need. So if you dial 1-800-273-TALK, you're going to get the exact same responses if you dial 988. You know, it's really no charge for the end user. Now, standard data rates may apply for mobile carriers who, you know, if you're texting to the Lifeline, so you can't say that may be absolutely free. Now, this doesn't mean that there's no cost to run the system, just that there's no cost to the person in crisis. Now, in California, in September of 2021, DHCS dedicated $20 million to support the infrastructure needed for 988 to be fully operational. This was increase the technology, the capacity, the technology, the infrastructure, equipment, training, to go ahead and really kind of get the system ready for what we're seeing is going to be a huge influx coming in. For ongoing sustainability, California is one of the first states. I believe there's only 5 now that have passed legislation. There's a plethora of them that are actually currently in legislation. but California passed legislation supporting ongoing funding through AB 988, which really kind of says is that from a telecommunications surcharge, we can have a discussion a little bit about that. That in 2023, 2024, it's going to be 8 cents per month per access line. And then after January 1st, 2025, what will end up happening is they'll kind of see what the actual cost for these services are. They'll create some algorithms and kind of back into what that service charge or surcharge is going to go ahead and be, no greater than 30 cents per access line per month. Feel that's probably going to be in that sweet spot and make sure that everybody has access to the service. Fairly similar to how 911 is funded, based really on the same kind of models. The bill also created the 988 State Suicide and Behavioral Health Crisis Services Fund, which would require the fees to be deposited along with other specified monies into the fund. So there's still an option for the state or counties to put money into that. Additionally, that bill appropriated $300,000 from the general fund to the 988 State Suicide and Behavioral Health Crisis Service Fund. And once again, there's other options and other funding opportunities for that. Currently, a lot of counties are actually probably funding their own crisis line. There may be some opportunity to continue some of that. Does 988 accommodate those that are hard of hearing? Absolutely. Lifeline currently serves TTY users either through their preferred relay service or by dialing 711 and then the 1-800-273-TALK Lifeline number. Also offers services through text and chat. Lifeline is in the process of expanding the video phone service to better serve deaf or hard of hearing individuals seeking help through 988. So yeah, absolutely. Once again, the focus of the SAMHSA guidelines is anybody, anytime, anywhere, including those that have language issues or some other issues that require accommodation. So the answer for that one is yes. Does 988 use geolocation? We talked just a little bit about this one. Lifeline greeting states that calls may be monitored or recorded, but they're not going to be able to utilize a geolocation to the extent that people think that they are. There is discussion. The focus is that trying to get there. So in 2020, part of the 2020 Designation Act, the Federal Communication Commission submitted a report examining the feasibility and the cost. And really where they went with that is we want to go back and we want to think a little bit more about it. So they started to hold forums. I think at some point they may move into geolocation, but at this point it's still something that is being discussed. So at this point it's no for geolocation. The reason I do think it's important for this is somebody who used to work in these crisis lines that didn't have the ability to trace a call. When people call in, they're in an absolute crisis and I don't know where they are. It's hard to go ahead and send a rescue unless I can get information from them. But frequently, if the belief out there is that they know exactly where I'm going to be, all I need to tell them is that I've taken some pills and somebody will come and help me. And that's actually not the case. The second reason this is important is people who have paranoia or don't want police intervention, afraid of some kind of police intervention, won't actually pick up the phone if they think that they can be tracked that way. So currently, no, may change. Will calls be recorded? This is the only maybe that we've got. Let's go ahead and press the button on that. So ultimately, 200 case or 200 call centers across the country are part of the 988 system. Some actually record calls, some don't. Depends on the technology, depends on the leadership for those particular programs. Sometimes it depends on the size, sometimes it depends on the funding. You know, some call centers will actually record everything that comes in, whether it's on the 988 call, whether it's on their regular call in coming in, whether it's on 211, whether it's actually even a backline the police or other providers might tend to use. It's also important to note that the people contacting 988, they're not required to give any personal data to receive services. This data is basically used to make sure that staff are trained, that if there is an issue that it can be kind of addressed. So like I said, it's something that is going to be very specific, and I'm not sure which percentage of crisis call centers tape everything and which percentage don't. My instinct is probably more don't record than actually do. Does 988 pull any funding away from 911? I think a lot of people are concerned about that, and the answer is no. It doesn't. They're funded fairly similarly, but they are funded separately. So you can just see this, and I'll, in the effort of time, I'll kind of run through this one, just a little bit quicker. So you can kind of just take a quick peek there. Short-term goal is to get the 988 able to go ahead and handle 9 million calls this year, 24 million calls in 5 years. But the long-term vision is to go ahead and support an integrated system of essential services for people with behavioral health crisis systems. Is the challenge of 988. So as we're looking there, it's easy to make the analogy between 911 and 988, but they are dramatically different, other than they will serve anybody, anytime, anywhere, and they will always pick up the phone. So part of the difference between 911 and 988 is 988, the focus of the call is going to be stabilization. Their goal is to help somebody stay in community and to stabilize and not require any more system intervention other than the call itself, which once again should happen 88 to 92% of the time. So it's got a little bit different focus. The other thing that we end up seeing is that, and a report just came through NRI at one of the SAMHSA meetings this morning, is about 34% of the 988 call centers have the ability to dispatch a mobile team. Overwhelmingly, they don't, which means if I am talking to somebody who needs crisis services through 988, I may need to get connected into a different agency or a different program, state my case again in order to get a mobile team that's coming out. Whereas 911 dispatches, they're able to dispatch. There's dramatic different technology utilized in 911 versus 988. And you can talk a little bit about what Cal OES does to kind of standardize some of that technology. But overall, the 911 technology is far superior to that of 988. Maybe not in the electronic record keeping type of thing that you would have with 988, but the ability for the system to never go down, the ability to go ahead and track where calls are coming in from, the transfer capabilities are something that are significant in 911 that we need to work a little bit more toward. Training requirements are different. A lot of 911 across the country is going to be trained through the local police academies. That service that's starting to come in. Training requirements for those 200 call centers are going to be dramatically different from call center to call center. There is a little bit different between 911 being government employees versus non-government employees. And what we do tend to see is 911 tends to be much more protocol driven than 988. So the question really pops up is, how does this start to impact? So once again, 240 million calls coming through 911, 3.6 million calls coming through 988. We anticipate 24 million calls coming through. If I think about 10% of the calls coming into 911 as being appropriate for 988, that's my 24 million. The APA actually believes that number should be 20%, which gets us to about 48 million calls coming through. But how it impacts is some of these differences may make 911 dispatchers less likely to send a call over to 988 if they feel that they're going to get a service that's not comparable quality-wise with 911. So all of these things that make us a little bit different sometimes make us siloed. And that's part of the challenge that we're running into is how do we fully integrate 911 and 988 into a system where calls get transferred back and forth with a high level of trust and a high level of confidence that that's the appropriate level of care for that person that's in crisis. So let's jump one more. So there's obviously a need to collaborate. These are just some of the numbers. Once again, I think it's going to move forward. But what I can tell you is that in California, if 911 and 988 don't have collaborative protocols, don't have trust, don't have faith, don't have accountability, the system's not going to work, and 911 is going to continue to take those calls and just solve their problems by sending police officers when mobile teams may be more appropriate. So that's what's getting in the way of transfers. I want to talk just a little bit about, and go ahead and hit the button one more time. We'll get to accountability here as well. So really what we take a look at is what I've got here, County of Los Angeles. This came through law enforcement in the County of Los Angeles. D.D. Hirsch has a program that they're accepting calls transferred immediately or from the PSAPs in Los Angeles County. And this was started as a pilot. Might have moved on to a pilot. I found this actual chart online. I did a lot of work in LA County and helping them redesign their system. So I had access to this little graph. I like it because what it's starting to do is protocolize how the collaboration between 911 and 988 occurs. And there's a lot of paperwork underlying this, a lot of protocols around that, procedures that happen as far as when calls get transferred, when they get transferred back, what the documentation is, how they keep track of everything that's happening. But really what we started to see is that the agencies that are doing best in that collaboration between 911 and 988 are working together to protocolize exactly how this looks. When we're working with PSAPs or 911, they are highly protocolized. That's how they ensure safety. We do the same thing in this case. We know exactly what we're going to do when this comes up again. We don't do that as much on the behavioral health side. It's a little bit more kind of in the moment, but we need to get to those levels of protocol so that 911 and 988 can work together. So here's where we go from here, I do think. We need to focus on managing the increase in calls that are going to start coming in. Once again, going from 3.6 to 24 million in 5 years, that's imagine any agency doing that. We need to ensure that all call centers have the technology to act as that air traffic control hub. They've got to have the same technology, maybe different technology, but same capabilities, you know, the same consistency, the same security that 911 PSAPs are going to have. And there's a lot of technology out there that can support kind of integration between 911 and 988. We need to make sure that call centers have an easy way to dispatch mobile crisis teams. So 32 to 34% of 988 is dispatching mobile teams. Probably needs to be 100%. If not, we're delaying or denying care for folks. And we need to increase the marketing to go ahead and max out the people are calling 988 directly, as opposed to needing to go through 911, where we've got some of these issues as well. We're all in this together. My email's still up there. If you've got any questions, if you've got any answers, if you've got any solutions, please let me know.